The injection sites and like kind of the angle of insertion for the radiocarpal joint and the distal radio-ulnar joint. I think for the distal radio-ulnar, I remember you have the styloid process of the ulna. You come like proximal to it and then a little lateral, and then there should be like kind of a dip and you go just straight in like that.
For the most part, yeah.
And then I don't remember the radiocarpal one.
So when you're palpating, right, so start on your third metacarpal, palpate back until you feel the depression. What bones are you going to have in that depression?
Capitate.
Capitate. And then when you go, and is that in the proximal or the distal carpal row?
Distal.
Right. So then when you go a bit further proximal, what do you come up to?
Triquetrum?
Nope.
Lunate.
Lunate and scaphoid. Yeah, if you actually come basically from that depression, if you go like a few millimeters towards the thumb, towards, generally where scaphoid is, because scaphoid's this like, almost like kidney bean shape, and it comes over like this. And so you actually can, in here, get to the scapholunate joint, which is access to the mid-carpal joint, and then you need to go just proximal to that.
So you find the depression of the capitate.
Yep.
You go a little bit lateral. You should feel the scaphoid lunate, and then a little bit.
Well, you have to go proximal to feel. So once you feel the capitate, you have to go proximal to get to the proximal carpal row to feel scaphoid and lunate. And then you go a touch more proximal.
Okay, and then are you feeling for a depression, or
it's very very mild depression that you'll feel. Like I basically can feel it under my thumbnail here. But again, the difference in these areas is like this much. Like everything is so close. And maybe later, at the end of the day, if we have time, we'll scan a wrist under ultrasound so I can show you really how close these joints are in proximity. Yeah.
Are they somewhat continuous, like the proximal carpal? So if you were to put fluid into the proximal carpal row, would it just stay within that small tiny joint, or would it spread a little bit?
So that's actually a not well researched area in terms of anatomy, and there's disagreements on that. And what I actually think it comes down to is I think it's going to be like each person is going to have a slight variation. Like even the TFCC, for example, where the ligaments attach, and if they split into different bands, like there's a wide variety of things that can occur. The most common thing appears to be that if you access the basically the carpal row, whether you do it through the proximal or the distal carpal row, basically you get into the mid-carpal joint anywhere, that flows throughout all the carpal bones. That seems to be the most standard. That won't connect with your proximal carpal joint or your radiocarpal joint. It won't, obviously, with the distal radio-ulnar joint. Those are separate compartments. But generally, if you get into the mid-carpal joint, which I access through the scapholunate joint because it's easiest to palpate, that is supposed to spread. And have you seen Bethel do a wrist under fluoro yet? You can see it under fluoro. If you have enough ligamentous damage to the wrist, you can actually have a continuation, like it blows out, and you'll watch the contrast spread flow into the radiocarpal joint, and it becomes a cluster. Or sometimes it doesn't, and we had this on a patient that I had where we went through the scapholunate joint and it didn't spread over to the medial aspect of the mid-carpal joint, and our suspicion is just it's scar tissue that's been laid down that then end up blocking off access to that part of the joint. And so that's one. So I like the ultrasound for injections into the wrist joint, but I think that's one of that and the ankle, I think, are areas, especially when you're doing the same thing, right? You're trying to inject the mid-tarsal joints. With that, I think fluoro just adds an additional layer to it so you can make sure you're getting everything that you need. Yeah. What else you got?
Femoral acetabular hip syndrome or femoral acetabular impingements. Options for people that aren't getting basically any results from conservative care. People that are going inside the joint and basically non-surgical.
Right.
So corticosteroid injections inside the joint, physiotherapy, that kind of stuff.
Is this, are you asking more about a functional FAI or a true, like, cam pincer deformity?
Non-cam insert deformity. So I guess if they came in with imaging, which a lot of them do, because they've already failed everything,
Right.
then they theoretically they would have found a cam pincer deformity on imaging, and so we would presumably be dealing with a functional issue or common things that you see or refer pain that look like FAI.
Right. So let's say we'll take this in steps. Let's say we rule out other things, and we actually think this is a function, what I would call a functional FAI, meaning it's not a structural FAI in that you've actually got a cam or pincer deformity that's actually abutting against the head of the femur. So it's functional. The generally what has been my experience with it is that the head of the femur has been anteriorly translated in relation to the acetabulum. Okay, that then puts, because the way, and I wish we had bones in here, but that essentially what it does is it takes two parts of the head of the femur and the acetabulum and approximates them more closely so that when you go into flexion, you end up pinching. And then obviously you're going to pinch labrum and joint capsule, which is part of the pain that's occurring. So I think of it in terms of I don't want to say bony misalignment in the sense that just an adjustment is going to resolve that, because obviously the patients that come to us have usually gone through chiropractic and that kind of stuff. And so I think of it in two aspects. One is the muscles that are attaching onto the femur that can anteriorly translate the femur could be involved. One of those could be psoas, right? Because the way psoas is coming off the pelvis, attaching onto the femur, if that gets short, yes, you're going to have a change in the low back, but you can also have a mild translation of the femur. And then I also think about, if the femur is being able to be pulled anteriorly, similar like with a shoulder, if a shoulder dislocates anteriorly, we're going to have issues with the ligament on the front, but what about the posterior capsule, right? So maybe that the posterior capsule and the posterior aspect of the ligaments aren't taut enough to stop that anterior translation of the femur. So generally what I do is I'll do Prolo or PRP, and I'll specifically target the posterior aspect of the joint, making sure I hit the acetabulum and the surgical neck to try and actually get the capsule. And then the other is a posterior distraction, which I actually learned this from Kelly Starrett. So this is basically how I walk patients through this is you're going to find a soft/hard surface. You're going to rest your knee onto that hard surface, and you want to try and put as much weight as you can through this hip joint. And so you're going to end up coming off the other foot, and usually I just have them wrap it behind so that they're resting in and not holding this up. And then from here, it's literally just trying to relax, and they do 2 minutes a side minimum, trying to relax. And what you'll feel is you'll actually feel the posterior capsule, because that posterior capsule is, while it doesn't have the integrity, it's also really locked down. And so you can actually get some increased translation of that head of the femur in the acetabulum by doing this posterior distraction. And so usually what I'll do as a test with patients is if they come in, they have this, I'll say, okay, let's do this in office right now, and let's do just one side, and then let's retest your squat. If they retest their squat and the side and let's say it's bilateral, the side we didn't do anything on, if that remains painful, but the side we did something on drastically reduces, then that's going to be confirmation for me that we can impact this by just trying to help relocate the head of the femur more posterior in the acetabulum. And I'm guessing this is like, we're trying to move this like 3-4 millimeters. Like, it's not a huge thing, but it's got to come from the neuromuscular system, the ligaments, like all that stuff. And so it's generally how I would approach it.
Okay, then for at-home care after that, would you strengthen the glutes, like glute max, try to posteriorly translate it, and then mobility in the anterior hip?
Yep. Anterior hip mobility. So it'll be psoas, rec fem, and the posterior hip distraction. And then strengthening erectors, strengthening glutes, strengthening hamstrings, everything that is on that posterior chain that's going to help create tension to keep that posterior.
Okay. Do you use resistant band? Do you ever do that resistant band where you lock it up near the hip and get into an extension as a posterior translation with that? Yeah. Would that do pretty much the same thing?
I have seen the knee driver do much more in a shorter amount of time.
It's simpler too.
Yeah, than getting the band around and getting into that lunge position, because in that position too, then you've got a lot of play that you've got with the pelvis that can change where you're gonna loosen and things like that. Right. If someone's more CrossFit oriented and like using bands for mobility is like that's already a part of their nature, I'll include that. But if it's just someone who doesn't, then just doing this and instead of having them fiddle around with bands, getting one that's too strong, they put it on, they fly backwards. But I think the posterior hip mobilization is huge for that.
Okay. Yeah. And then what about common issues that refer pain and mimic FAI or functional FAI?
SI, okay. I'd say, is probably number one.
Okay.
And that's just because when patients are in the positions that are going to generally aggravate FAI, right? A deep squat, for example, or just sitting with too much flexion, is you're placing more strain on that SI joint, especially the ligaments.
Okay.
And plus SI can so commonly refer over to that anterior hip as it wraps. Mm-hmm. And so that's probably the number one. I don't think I've ever seen facets refer to or mimic an FAI, although I've had facets refer to the legs but never mimic an FAI. And probably part of that is because when you go into a squat, your facet joints are going to open up a little bit.
Any peripheral neuropathies that commonly, or?
So you can have it's usually ilioinguinal and genitofemoral that you're going to see, and iliohypogastric that you can see. Most people will actually think it's anterior femoral cutaneous, but anterior femoral cutaneous usually actually starts about here for sensation. This part up here of the hip joint proper is more ilioinguinal, genitofemoral, and iliohypogastric. And so I've had, that I can remember, I've had 3 patients that were like their FAI responded to that, and we didn't have to go to do Prolo. I had one patient who actually, she had a true cam deformity, and we tried perineural at first, and she got 2 hours of relief, and then it came back. We did it again. She got 2 hours, so we knew that we needed to address deeper. We did Prolo and Traumeel for 1 round or 2 rounds of treatment, and she didn't get any better. And then so this is actually the last time I did a steroid injection, but I did about a quarter dose of a steroid into the hip joint and resolved it. I haven't seen her as a patient in probably 3 years, so I don't know if it came back, but I'm pretty sure it was at least 9 months when I had talked with her after that the pain stayed away. So So again, I think, and it's funny, it's the last time I've done a steroid shot, and that was probably 4 years ago. Yeah. Because I was still a student then. But that's kind of how I would approach it.
Okay. And genitofemoral and ilioinguinal intraabs, do they tend to happen somewhere along the posterior abdominal wall, or is it pretty local, like close to the ilioinguinal ligament?
let's see, I think they both are going to pass through deep to where iliohypogastric does. I think genitofemoral is a little more anteriorly when it comes through the deep abdominal layer, but through the superficial, I think is where you're going to get most entrapments, just because of how much fascial tension you can have kind of over the ilioinguinal ligament and things like that. Yeah.
Cool.
So that's usually a common problem associated with that.
Yeah, I think
Yeah.
for that exact reason.
Yeah.
Like just thinking like if they've been through PT and that kind of stuff.
Yeah, usually PT would resolve a lot of the muscular.
Yeah, theoretically. Depends on what they did.
Yeah, again, quality, right?
Those variants.
There's, in every profession, you're always going to have that range. So.
When it comes to like groin pain syndrome or just groin pain,
Yeah.
Aside from evaluating like strain of the muscles that can be involved, what common referrals do we see with groin pain in regards to low back pathology? Is that something?
And are you referring to like pubic symphysis groin, or are you referring to?
No, more lateral, more like in the hip crease type of groin pain.
Oh, so that's kind of the same answer as that. So
Okay.
the things that are not hip joint that can refer pain to the anterior aspect of the hip is usually SI, and then the peripheral nerves in that area. So ilioinguinal, genitofemoral, iliohypogastric.
Okay.
Yeah.
Makes sense.
Any other questions?
I have a prolo question.
Yeah.
So I know there's a standard amount of solution we know we can put into a joint, right? If I recall correctly, small, like the knee and shoulder, 4 to 6 ml. Is there any benefit to fully filling that joint capsule until there's maybe, resistance and we know that it's full on our end, or can that be risky?
So this is it's a really good question, because I think it really gets at a deeper concept in our prolotherapy world, which is if you talk to some of the elders, like you put 10 cc's in a knee joint, you put 10 cc's in a shoulder joint, you put 5 cc's in an SI, and while it's not like they're blowing out everybody's joints and all their patients are having complications because of that, I just think that there's a threshold that it's kind of like the concept of an LD50, right? The lethal dose, a dose of a substance that will be lethal in 50% of the rats or humans that ingest this, right? I think at 5 cc's in a shoulder joint, the chance of blowing the capsule is extremely, extremely low, and that chance goes up a little bit when you get into the 10 cc range, right? So I think the one time that there's an advantage to trying to expand the joint capsule is when we have adhesive capsulitis. And we've seen that 4 or 5 times now here, where doing that hydrodilation where we do 20 to 30 cc's, we really get an improvement in range of motion and symptoms. Mm-hmm. Outside that, I don't think that there's a benefit. And I also think it's really difficult to know when you're going to get that to that point where the joint capsule is going to separate and you're going to have leakage of fluid. And that thought process comes from an article that I read this probably last year, the year before, but it was looking at what's the accuracy of injecting the subtalar joint with just palpation based, so no imaging. So what they did was they took basically pain med docs who that's what they do day in, day out, is they do joint injections. And so they'd be considered highly skilled. And they looked at, okay, when that doc thinks they're inside the joint, then they would inject the contrast and look at fluoro. So they're basically trying to say what's the accuracy of doing a palpation-based subtalar joint injection. And interestingly, they only injected 3 cc's. And I don't remember the exact number, but the range was something like 10 to maybe 30% of those patients, they saw extravasation of the contrast outside of the joint. Now, none of these patients had ankle pain, And so their thought was that maybe 3 cc's in the subtalar joint is too much. And in some patients, you're blowing out the joint capsule and then you're causing. But at least from the discussion, I don't think any of those docs thought, oh, I'm about to blow the joint capsule and there it just blew. Or I feel like they would have stopped before that and not just continued. But again, that's also an assumption from the study. But so I don't think that, I think there's certain scenarios where we're not going to feel that joint capsule giving out, especially if there's a weakness in a particular area.
Can we talk about, I don't know if it's relevant anymore, exosomes, or just the different types of products that are out there that are available for injection?
Yeah. So how I kind of classify our products is we have our amniotic fluid type products, and I will also categorize like the amniotic membrane stuff. So basically our true amniotic products. Then we've got the like the Wharton's jelly, placental matrix type products, the exosomes, and then the umbilical cord products. The umbilical cord products I completely stay away from for several reasons. One is that's mainly hematopoietic stem cells, not mesenchymal stem cells, and so a lot of, I think, what companies will claim, they're making claims for what a mesenchymal stem cell does, not a hematopoietic stem cell. And I also just don't trust those companies because they make claims that are not founded in their research or third-party research saying that we actually have stem cells. And that kind of applies for a lot of companies. So as a personal opinion, I won't ever work with a company if they tell me that they're basically in violation of the FDA, which is the FDA currently states that that products that are off the shelf cannot contain live stem cells. The one exception is if you have a cord blood product, but that cord blood product has to be used for a homologous condition, which basically means it's only approved for use in cancer, where you have a bloodline cancer like a leukemia, and it has to be used in yourself or a first person relative. And so my future child, we could take the cord blood, we could store it, they could process it into where I can get it back later, and that's now considered a product. And I could do that for myself, for my kid, for a sibling, because it's a first degree relative. But you can't just go to a cord blood bank and go, oh, let me get some cord blood and let me inject these live cells into somebody else, because the FDA doesn't allow it. And so so that's the FDA's position right now, is nothing off the shelf can have stem cells in it. And so any company that claims they do, I immediately won't work with them. Exosomes is a slightly different aspect of this because it's a non-cellular product. It is the secretions of a cell, and up until about a month ago, the FDA was kind of quiet about it until they came out and they publicly announced that they view exosome products as cellular drugs, because even though there's no cell there, you have to start with a live mesenchymal stem cell, whether it's from a bone marrow MSC or a placental MSC, and you have to then create this product out of a live cell product. And so my use of exosomes is basically going away right now because I have no desire to be in violation of the FDA saying, hey, this is a drug and these companies shouldn't be producing it. So those are kind of the different camps. So prior to all the FDA stuff, the two main products I was using was exosomes and a placental matrix product from Sky Biologics. I liked the placental matrix product and some more of the amniotic membrane products can be good for this, but you get a better scaffold with those things because there's actual tissue in there. There's collagen fibers and strands and things like that, and some hyaluronic acid, extracellular matrix, so you have more substance to hold on to cells. The exosomes, amniotic fluid, that stuff there's no scaffold to it. It's free flowing liquid. And so I would generally use the exosomes when I didn't really need a scaffold, or where we can't have a scaffold. So for example, in a caudal epidural, you don't want debris to go into the epidural space, which is why in the conventional world, you use a non-particulate corticosteroid like dexamethasone, right? It's not cloudy. When you look at dexamethasone, it's clear. So you wouldn't use, Medrol or anything like that. And then I used the placental matrix when I wanted a bit more scaffold. So for joints, for nerve hydrodissections and stuff like that.
Along those lines, Dr. Timmermans, could you just speak to the difference between hematopoietic and mesenchymal stem cells?
So the hematopoietic cell lineage gives rise to our red blood cells, white blood cells, platelets, okay? Hematopoietic stem cells are going to be found mostly concentrated in the bone marrow because that's where our body is making the red blood cells, white blood cells, and platelets. And then obviously there's a lot in the spleen as well, and our other organs of erythropoiesis and things like that. So they are not able to differentiate in a lab into a myocyte or a tenocyte or a chondrocyte or anything like that. That's the mesenchymal pathway, where that's going to turn into bone, cartilage, ligaments, tendons, muscle, fascia, that type of stuff. That doesn't mean that hematopoietic stem cells are not beneficial for orchestrating the healing process, because they are obviously can be helpful for generating new blood vessels, the hematopoietic stem cells. And so like when we do a bone marrow procedure, for example, we're getting a lot of hematopoietic stem cells, which can be still beneficial in orchestrating the paracrine effect of the healing process with stem cells. But I believe that it's important to have the mesenchymal stem cells with the hematopoietic stem cells. And that's just a theory. I don't think there's ever been a study where they've taken bone marrow and they've looked at side by side on what happens if we keep the HSCs in versus taking them out, or what happens if we keep the MSCs in or if we take the MSCs out. But that's just my hunch, that if you're trying to orchestrate healing of the mesenchymal pathway, you want mesenchymal progenitors, right? Your mesenchymal stem cells. But even like with an adipose procedure where like we do a tissue transfer, you'll still have hematopoietic stem cells present in that, because obviously we still need those hematopoietic stem cells for blood vessel growth and that kind of stuff in other areas outside the bone marrow and the spleen and stuff. But those are kind of our differences.
Okay, thank you.
Yeah, so pericytes are, and this is still actively being looked at, but basically pericytes are dormant mesenchymal stem cells. And so what happens, which is when you think about that, how smart is that? Because what happens when you have damage, right? Blood vessels get broken. Then those pericytes sense they sense that there's damage. They dislodge from the blood vessel, and then they sense their environment, and then they either become a type 1 or a type 2, which has to do with inflammation versus non-inflammation or non-inflammatory MSCs that then start to orchestrate the healing process and stuff like that.
Along those lines, I'm thinking, have there been any studies to show whether just like I'm thinking like a dry needling, but just with an actual hypodermic needle into areas of pain could in itself cause, small capillary damage and then pericytes to be mobilized?
So I don't know if they've ever gone as far as looking at, do we get pericyte mobilization and things like that. But there is a lot of documented research, which is one of the big criticisms of prolotherapy initially, was that there was research showing that there's what's called a needling effect. When you put a needle into an area, you create damage and patients heal because of that. And so for the longest time before we had good studies on comparing, saline as a control, which is still not even a great control because I think saline even has healing properties when you inject it. But basically when you take non-injection, so just needling, and compare that to injecting a solution does better than needling, but needling still works. And so I think there's a lot of potential for the dry needling practitioners, like that community, to do a lot more. I think I wish they took the approach more of doing it in a prolotherapy style fashion, as opposed to just trying to find the trigger point in the muscle and then hammering the hell out of that. And which is extremely painful, but I think that approach is correct in the sense of using a needle to try and create change. It's just I think that they would do much, much better if they focus on the end thesis, right? But yeah, there's definitely a needling effect. I also think that's why patients get better with gua sha and scraping. Because you're breaking blood vessels, you are causing mesenchymal stem cells to be released in that area, and that's initiating a healing response. And sometimes that can be, as I know we've all seen, can be enough to help get patients out of pain. Okay, so tell me which back pain.
Alright, so
When did it start?
Yeah, it's been going on for off and on, about 4 years.
Okay. Did anything happen before that initiated it? Any injuries, car accidents?
You know what there was?
Kung fu fights?
there was an injury.
Mexican street brawls?
No, not unfortunately, staying out of trouble. But actually a big slip up at Slide Rock.
Okay.
I was
The irony.
I know, slide. Yeah, literally slid out, chasing what was it? Have you heard of it was a cross between an apricot and a plum quat.
You were chasing a fruit?
It was rolling away. And
You can't make this up.
No, I can't. I go to chase
so
after.
glad this is on film.
I paid a premium too. It was like $2 a plum quat or whatever it was called. Yeah, it's dinosaur egg. It was really delicious. It starts rolling away. I start to chase it. I slip on some algae. Both legs come up, and I come right down, straight on my left PSIS, kind of low back area.
Okay.
And since then, it's kind of, got real bad. We addressed it with some castor oil and like some soft tissue at the time, but it's kind of like lingered ever since.
Okay. What's it feel like?
Feels like an ache, like just a general.
Okay. And where?
I'd say it's located on the left side of the low back, close to the sacrum.
Okay. Any radiating pain?
No radiating pain. Maybe an associated. Sometimes I'll get hip pain, like today actually.
Okay.
I've been having
Kind of wraps a little bit.
I may wrap.
So when you see this, you can. It's classically called a C sign, which is usually attributed to a labral tear. But because of the way that SI radiates, I also consider SI in that when patients go, it kind of wraps like this, right? They're making that C sign. Okay. What makes it better?
Let's see. Hot showers.
Okay.
A hot shower, that helps it out. I was doing some.
So that tells me muscle relaxation helps. Okay.
It was more for the radiating pain or the posterior hip pain, but I was doing some piriformis kind of stretching, kind of pulling this up like that.
Okay.
Holding that. I noticed after doing that for a little bit, went down a bit.
Okay. Anything else?
I don't think I've done too much else. Oh, some frequency. I do sometimes some microcurrent.
Okay.
That helps with it.
Have you ever taken any NSAIDs, any pain relievers, any muscle relaxers?
No pharmaceuticals, but I'll do like proteolytic enzymes.
Okay.
I noticed that that helps.
Okay.
So I did turmeric for a while.
Okay.
It was getting better.
Okay. So I always ask point blank if because a lot of patients they'll have tried an opioid and they'll have tried it for a week and it didn't help. So when you're asking like, what helps, what makes it worse, it's you're not actually asking what have you tried that didn't work. So I always point blank ask about NSAIDs, opiates, muscle relaxers, and then depending on the type of pain, if it seems more nerve related, I'll also ask about like gabapentin or pregabalin or basically our other neuropathic agents, because all of those help tell you stuff about what's going on. What makes it worse?
So you know what? Certain movements, but it's none that stand out in particular. But maybe if squat. Oh yeah. Like if I'm squatting, if I don't watch my form really carefully, it'll aggravate it.
And what aspect of your form? Like, is it knees fall in? Is it low back rounds? Like what?
Yeah. It's the low back. If I don't guard the low back, I'm not.
So if you don't maintain an arch.
Yeah. If I'm not engaging the core, if I get sloppy and engaging the core, maintaining the arch,
Okay.
it'll aggravate it.
So already right now, facets like just kind of dropped a little bit on my list. I'm still going to evaluate for it, but because if he loses the arch in his low back, what happens to the facet joints? They actually open up.
Yeah.
Because extension closes the facet joints, and so if he goes from here and when this happens, his pain gets worse, it's likely telling me, now again, it could be the capsule of the facet joint, so I'm still keeping facets in the picture, but facets kind of drops with that because of that. Okay, anything else you can think of that you think is important that I don't know?
I have the only other pertinent maybe medical history. It's like mild scoliosis could be going on, but other than that, it's nothing else.
Okay. Any numbness, tingling, weakness, loss of bowel function, loss of bladder function?
No.
Okay.
No. A week ago, I had my second toe. My second toe, I noticed actually had some tingling. It
Okay.
lasted for about 10 minutes. It was pretty interesting.
Okay.
That's it.
That ever happened before? Just the one time.
No, just that one time. Never happened again.
So likely just an incidental thing because this has been going on for 4 years and this happened once in 4 years. So that's an HPI. Okay. You could that was what, 6 minutes. So you can really condense into the really important stuff on knowing it's your basic OPQRST, just keeping it really condensed. And that will come over time as you guys start to learn that I could sit here and talk for 20 minutes more about his pain, but I already know enough about it before going into my exam. So differentials at this point, probably top 2 are going to be sacroiliitis and then a middle or superior cluneal nerve neuropathy. Would be a mononeuropathy if it's just one of them involved. And then facets are still at play. And those are the big 3. So let's do some, I always start with range of motion, so flex forward at the hips. No, stay seated, yeah. Any pain?
No.
Okay, go into extension, so chest all the way up to the ceiling. Any pain?
No, not there.
Okay,
Did that.
let's turn and look over left side. Any pain?
No.
Okay, turn and look over right side.
A little bit.
Where? On the left?
Yeah, right in there. Not so much. Where I feel the pain, but a little higher.
So this is always a good thing to clarify. Is that the pain that you're seeing me for today?
No.
Okay, so we may have something going on with facet joints, because remember, when we turn this way, what happens to the contralateral facet joints?
Compress.
They close down, they compress. And so we may have a facet thing going up higher, but either the pain from this because of pain gate theory, the pain from this is basically that's what his brain is focusing on, and so you don't feel the other pain, or it's just not significant enough for it to actually affect his day-to-day. Excuse me, because he's rarely ever in this extreme position, right? Okay, let's lay on his back. All right, nice and relaxed, nice and relaxed. Any pain?
Yeah, it's a little bit more. Yeah, I would say I'm feeling that posterior hip pain when you do that.
And is that posterior hip pain, how does that fit into what you're seeing me for today?
I felt that pain in the back for just a moment though. During when you were bringing it up,
Okay.
it was elicited, but it didn't stay. Just for a moment.
The low back, you're
The
saying?
low back, yeah.
Stay relaxed. Let me know if it happens again. Nothing? Okay. I'm gonna bend the knee here. So we had straight leg raise, now we're gonna go into Faber. Take a deep breath and relax. Always have them breathe and relax, because there's so much guarding on the adductors. Any pain here?
No.
And then apply load. Any pain here?
A little bit.
And is that the pain we're talking about today?
Yeah.
Okay. So patients like Alan are who, it's that, what is that in TCM, the more lanky types? Do you remember
Wood.
what, the
Yeah.
wood type?
What type?
Your more wood type patients or your lankier patients, they're generally gonna have more joint play. They're generally more flexible. And so if I hadn't of, because this is, you'd think if he's got SI and this is going to be positive, like, look at this range of motion. But if this is not stressing his end range of motion, then we're not going to get a good test.
Mm-hmm.
That's why applying the pressure is important in that situation. Check flexion, anything here,
No.
okay? And then come into,
And the anterior hip, but not the posterior.
Okay.
Yeah.
and then fader, anything here,
No, not on the back.
okay. And we'll just run through this side, nice and relaxed. Any pain? Okay, we're gonna bend the knee. Relax. Any pain? Any pain? Okay. Anything here? Anything? Okay. So then we can check let's have you scoot towards me a little bit. These are one. Oh, sorry, that way. Yeah. This is come off. Anything here? This is a modified chems test, but you'll also get some SI involvement with it. This is really great for your elderly patients where they have very little range of motion, because this is the least sensitive test for any extension in the low back. Because this will cause some mild extension in the low back, but not a lot. So I would never, even if he had facet stuff, I would never expect this to be positive on him. It's more so like your 60, 70, 80-year-old patients. Then we can come and check Gainsland's here. Any pain here? Okay, I'm gonna apply pressure. Any pain?
No.
Okay.
That's left-sided, Gainsland's.
Technically, yes, left-sided. Even though, remember, because you're getting a rotation and a counter rotation on both tests, you can get a positive on both sides.
But for charting purposes.
Yeah, for charting purposes. This off. Anything there? Anything here?
A little bit
On the left side?
on the left side, yep, in the back and the front.
Okay, and is this different than what I just did, flexion at the hip? Because you didn't have that on the back, correct?
No.
Okay.
It's it's tough because I think the anterior pain's a little louder.
Okay.
So it was a little different. That did cause just a little bit in the back.
Okay. So even though that's not a true positive for Gainsland's test, we know that we're getting a rotation in the SI joint on his left side with that, and so that still factors in for me. All right, let's go to our dial thrust. So remember, your hand, the thenar and hypothenar eminence are going to go on the sacrum. Your middle finger should be running up the SPs. Come up here and inferiorly drive. Any pain?
Yeah, a bit. In
Okay.
back.
And that's the same area that we're talking about?
Yeah.
You always want to be confirming that it's the area that the patient's seeing you for. Anything on this side? Okay. And then we have our, I'll do it from the side, SI joint distraction and compression. So remember, the action that you do is the name of the test. So distraction is going to be, so ASIS, ASIS, any pain? Okay, and then have you lay on your side. Bend the knees. Good. Remember with this, make sure they're stacked. You don't want them rolled back here, you want them stacked. You're going to find iliac crest, and I drive towards the belly button. Because if you drive towards the belly button, this is your axis, and that axis is going through the SI joint, right? So here. Any pain? No. Okay. And then flip to the side.
How often do you see SI compression or distraction being positive?
Compression or distraction, rare. I think I've had like 2 positives in the past year and a half that I've incorporated these tests. Or you can sit up actually. And compression, maybe 10% of the time that there's SI involvement. So, yeah, pretty low compared to your Gainsland's favor and thigh thrust. So usually those are the 3. And then palpation. So SPs, anything along the SPs?
Down there.
And is this familiar?
It is. It's just it's there. That's closer to where the
So
finger feels.
what happened there? You want to turn so they can see. Yeah.
Yeah.
Can I pull this up?
Yeah, absolutely.
So first palpation was here. When we were down here, he started to notice that he was feeling a little bit. When I did this, which was slightly going lateral, now I'm on the sacrum and he feels it. Remember, your ligaments for your SI joint attach sacrum to ilium. So if you're palpating the sacrum and that's recreating some of their pain, then you know the posterior sacroiliac ligaments are involved. And then here's our PSIS, so any tenderness.
Yeah.
And this is
that-
the area that you feel pain?
Yeah, and more so right in there.
Okay.
Yeah.
So that's SI. So, sacroiliitis on the left side.
Left side. Come on, left side.
But you see how we kind of worked through using the history first to kind of orient what we're looking for, and then the physical exam for, okay, how can we hone in what we learned in the history to be really specific. So a case like this, I wouldn't feel the need to do like DTRs or wet cold sensation for dermatomes, because I don't think there's a dermatomal component, and that might just lead us astray. So, yeah. All right, what's up, everybody? So we just finished up with a patient, and I want to take this opportunity to kind of talk about something that I see pretty frequently over and over again, and that is this notion that we can have underlying systemic causes that can contribute to a localized, pain generator or something like that. And so, one of those examples is being an underlying systemic condition that could be contributing to dysfunction of nerves. So whether that's a B12, a folate, a B6 deficiency, whether there's iron deficiency anemia, hypothyroidism, a progesterone deficiency can also sometimes cause some nerve issues. And that underlying condition can then predispose when there is a local trauma to a nerve, for example, whether that's in the shoulder or the low back, that the nerve has a harder time healing. And so when we're approaching these patients, we have to make sure that we're addressing the local tissues. We have to be addressing the damage that happened there, but then also we have to look at the underlying systemic contributor to why this even happened in the first place, and addressing both of those, so that way we can help the patient, one, get out of pain initially, but two, also long-term prevent that from happening again. All right, what up, everybody? So I've been using peptides a lot more lately, a lot more, especially with my regen patients. And so I wanted just to take a second here to give you a little insight onto kind of how I'm dosing those and what I'm considering. I'll keep this one brief just because it's been a long day and I'm ready to get home. But the number one peptide that I'm using in conjunction with my my regen injection, so whether it's Prolo, PRP, not using it as much for like perineural, but I am using it for nerve hydrodissection. But so we got our Prolo, PRP, our stem case, definitely our stem cases, our nerve hydrodissection is BPC. I get a lot of questions about injectable Bpc versus oral Bpc, and unless you are actually taking the Bpc and doing an injection with that Bpc in the way we would do Prolo or PRP or something like that, you're not getting a local effect if you subcutaneously inject the Bpc over the knee or over the low back or something like that, because it's not going to penetrate down all the way through those layers to actually get to the MCL or the SI joint if that's what the patient's wanting with a subcutaneous injection. Yes, you can do that with your longer needles, that we use day in and day out, but subcutaneous doesn't really impact efficacy of Bpc. And so I generally just go for oral because it's easier for patients to use. They save cost on injectable or like the syringes and all that kind of stuff. TaylorMade Compounding is the compounding pharmacy I use. It's basically the only source that I trust here in the US. I was actually just sent a website today asking me if this website was legit for peptides. And they were selling Bpc for like a tenth of the cost of what it costs through a compounding pharmacy. And that just scares the hell out of me because I don't know purity, because they don't say anything about, well, they claim purity, but they won't give any mass spec or HPLC or anything like that on their purity. I get concerned about sterility. Are they cutting corners? Is it even dosed appropriately? Just a whole bunch of stuff. And TaylorMade, they're great, and I really like them, so that's who I use. So in terms of dosing, generally I'm doing 500 micrograms once a day. I have experimented a little bit with 250 micrograms twice a day, but I think the 500 microgram once a day works pretty well. The effects of Bpc are reported to last about 6 hours, which is actually a good thing because we want this kind of cycle of cycling on and cycling off. We don't want Bpc constant. And so I think the once a day is super sufficient. Generally for most patients, post PRP or stem cells, generally doing it for about 4 weeks. If it's a larger case, so we're doing an adipose stem cell procedure and then we're treating anywhere from 3 to 4 joints, generally you're going to have those patients on Bpc. We may do other peptides as well, but generally going to be on the Bpc for about 2 months at that point, just because they have to go through more tissue healing. So that's Bpc. That's how I'm using it right now. Results are really, really phenomenal. And another thing that has been working for me well too is if you have a case where you do an injection and you are pretty confident in your diagnosis, you are pretty confident in the needle location and your placement, but the patient isn't having a great response, even if it's a few weeks out, toss in some Bpc. I'll generally do that for patients if, at the 4 week mark, they're not where I think they should be based on my experience and all that kind of stuff. We'll toss in some Bpc for a month. And I think I've had that on 4 occasions now. And 3 of the patients started to have a climb in their improvement. And so that seems to be working pretty well on those stubborn cases. All right, everyone. Hope you liked it. See you. All right, everybody. So rounding out today's Friday, rounding out our new series here, the RTH Regenerative Teaching Hour, which has it's going to evolve as we go through this. But I just finished a procedure with a patient that I think is an interesting case, just because we are not 100% sure if the procedure that we did, which was a nerve hydrodissection to the brachial plexus in 2 locations, which is an interscaling location and a supraclavicular location, which I'll touch on in a second, but just not sure if that is going to give the patient the results that we are hoping for. Now, to kind of preface this, the patient does have a pretty large disc bulge at 5, 6, 6, 7 that is causing central stenosis and is compressing the spinal cord a little bit. And so he's having some radiculopathy on one side and then some fasciculations on the other side. He has been advised for a double disc replacement for those 2 levels. However, he is looking at different things that he can try prior to taking that step of having a double disc replacement, at his age, which, I mean, he's under 40, so by no means is he old or anything like that. So what we did based off our physical exam, because he did have some changes that would indicate some thoracic outlet, so basically some compression of the brachial plexus in between the anterior and middle scalene, but also with pec minor. And so we did our brachial plexus nerve hydrodissection at the interscaling location, which is more so going to get C5, C6, C7 nerve roots, and then our supraclavicular region, which is going to give us more of our, you actually kind of get all levels, 5, 6, 7, 8, and T1. You don't get a few of the smaller nerves that end up providing some sensation to the shoulder, but we do get kind of the nerve roots that we needed to get for him in order to see if there was an improvement. Post-procedure, he did have what seemed to be a moderate improvement in his fasciculations and a mild improvement in his weakness. And so we will see if this is beneficial. And so just, I guess the lesson from this here is that, one of the things that I stressed in talking with him is that obviously surgery, while there are phenomenal things happening in the regenerative medicine space, we can't just disregard when patients are surgical candidates. And I believe he is a surgical candidate. He is just making a decision to try some other things that have some logical reasons behind them. Obviously, what we did was founded, meaning our nerve hydrodissection to the brachial plexus was based on our physical exam findings, the history of what's going on, that kind of stuff. And so he is taking those steps to try other things prior to making that commitment. But surgery it definitely needs to be discussed in certain situations like this. So for you practitioners out there, don't be afraid to talk to your patients about the possibility of surgeries. And if you don't know enough on what is a surgical referral, what's not a surgical referral, I definitely recommend diving into the research, looking at success rates of different surgeries, look at the indications for why different surgeries are done, so that way you can have a better understanding of that. I'd love to hear what you guys think about this new weekly format that's kind of piecing together just some different teaching stuff throughout the week. And this is obviously this is more geared towards medical students, physicians, different practitioners, and so I'm really going to try to dive more into my clinical thinking and that side of things to try and help you guys to become better physicians, better practitioners. Set together, we can help more people. So leave me in the comments what you liked, what you didn't like, what you'd like to see more of, so that way we can continue to evolve this thing. All right, see you later, everybody.